and she's awake.
A little tube? Does it go down my
Yeah, it's a tube, two tubes. One is the venous tube, which takes out the blood from the venous system and goes through a artificial pump, which is the heart, artificial heart, and goes through oxygenator where it oxygenates, and then you going back the red blood to the patient. So it is bypassing the heart and lung. You just maintain the circulation. Yeah, oxygenator. Yeah, you just ma'am, you just maintain the circulation and till your awakening happens and other urine output goes up, your liver goes fine, and all these things.
That's fantastic.
Yeah. This is known as eCPR, the ECMO CPR. Whenever your conventional CPR fails for 30 to 45 minutes, you put the patient on ECMO to.
Would you ever do it initially?
No, we don't do initially because it is an indication where you continue CPR for half an hour. If she is not getting awake or she is you're not getting an ROSC, reversal of spontaneous circulation, then you put her on ECMO. That is the thing.
And so do you not think that, I'm just very interested.
Yeah, please.
It's not too long without, half an hour seems to quite
No, it's half an hour is not considered too long, but the thing you have to know that it should be a quality CPR. It should be a quality CPR. The half an hour should not be. Yeah. That's why I'm going to present the patient who came to our hospital for the OPD visit, and she got arrested in the OPD because of some reason. So, and we started CPR at that point of time, went to emergency, they continued the CPR, but the reversal of circulation didn't happen for 45 minutes. And she got continuously getting arrested. And how we do revive this kind of patients.
Then do they go on, after you've revived them, do they go onto a machine?
Yeah, it's a machine. It's a machine with an artificial heart and lung support.
That's fantastic.
Yeah, so that's what I'm showing you. It's interesting. So, sir and ma'am, I'm Dr. Arpan Chakravarti. I am a critical care and ECMO physician from Apollo Hospital, Kolkata. So, I'm going to present a case today with a patient who came to our OPD in cardiology and arrested over there because of some reason. And we know the patient came. Is a 57-year-old diabetic patient, hypertensive lady with having some orthopnea for last 3 days and fever for last 1 day. Presented to cardiac OPD for a checkup, but there suffered a cardiac arrest and CPR initiated by the bystander and immediately taken to our emergency call for assistance, intubated and ventilated. So somewhat they achieved the ROSC and patient taken on ionotropes. Now after this, again, she got shifted to ICU and started having recurrent ventricular fibrillation, and CPR restarted, and we are getting some amount of ROSC, but because of the repeated cardiac arrests and recurrent VT and things were happening, and after an hour, they called us to do something because it was a resistant kind of cardiac arrest. So we, as a ECMO team, we have a ECMO team in our hospital, and we just attended the patient in the ICU. And we saw the heart is not moving at all in the echo, and she's having a recurrent cardiac arrest. So, and that part, you can see the heart is not moving, is a dilated heart at that point of time without any ulcer. Whether the rescue is possible or not, that's why now the protocol came that if we not getting an ROSC for after 30 minutes of CPR, and the cause is reversible and cause is the patient is young, we can put her on ECMO, do the ECMO CPR. So what we did, and this is your American Heart Association guideline for eCPR is recommended in case of cardiac arrest. Yeah, please. Yes. So the recommendations are usually the younger patients whom you are thinking that it's a kind of reversible cause, like an amine could happen, some poisoning had happened, or some kind of pulmonary embolism could happen. So a kind of younger patients who had an acute emergency, acute cardiac arrest, and probably have some reversible cause. You are thinking, you don't know, you are not sure. Like this patient who came walking in your OPD and arrested over there, probably it's a reversible cause of arrest we are dealing with. So we have to put her on some kind of support, some kind of circulatory support, so that got stabilized and we could know what is the reason for then if we could correct of this thing. So that is the candidacy of her, and this is a 2023 AHA guidelines where shows that if it is a recurrent cardiac arrest, you can talk for your ECMO CPR, that putting the patient on ECMO and do the continue the CPR after that. So yeah, please.
Out of hospital scenario cases.
Yeah, out of hospital scenario cases are also like that. If a younger patient you found in the, like in stations, you can find in the your airport where suddenly there is an arrest happened and a bystander has identified that he has started CPR on that, they also can be taken to the hospital or call the hospital to call for the ECMO team.
Is there any time limit?
Yes, it is there. It is there. The ideal time limit is between 20 to 45 minutes. But in a practical scenario, it is not possible. So we have extended up to an hour of time limit. If you can reach there within that time, you can start the ECMO at that point of time to make him awake. Okay, so this is the thing. Now, is field DCPR, field DCPR is there. We have done field DCPR also. But the problem in our country is that it is, as the awareness is not there, so you'll not get to know whom to call and at that point of time, because this thing, we are not into the OHCA till now, the out of hospital cardiac arrest on regular basis. But in hospital, you can always tell that if there is an arrest which is reversible, if the patient is younger, if the post-operative patients in the operation theater, in the cath lab, you can always call your ECMO team. Now, coming to the case, as look at this patient, having a severe pulmonary edema with a 10 of lactate, and this is the scenario actually happens, this thing. Somebody is doing CPR and we are cannulating the femorals. Okay, you are cannulating the both femoral artery and femoral vein. We are taking the blood out from the femoral vein and passing through an ECMO machine and pushing the red blood again to the femoral artery. So you have to cannulate two pipes in the groin, the femoral artery and the femoral vein. Vein will drain the blood, artery will push back the blood from the oxygenator. So this is the way we do, and continue to do CPR for this. And this is the usual scenario. This is a hurried environment. Nothing is very much appropriate, but you need to continue the CPR till you put the patient on ECMO. After the cannulation, we stop the CPR because circulation is done and patient is, we got a good mean arterial pressure. As the heart is not pumping, we got a mean arterial pressure, but patient put on ECMO with some amount of blood flow. So this is the way we, and this was the X-ray after 24 hours, started clearing with the thing on ECMO. We are getting, and this is the post-ECMO thing. The saturation is 72, because is having pulmonary edema. He started putting some amount of pressures, and the QRS is widened. He start getting shortened QRS. And this is the ECMO machine, which is giving a 2.4 liter of flow, which is probably adequate for her. Gradually, this is improving. The saturation is improving. The blood pressure is improving. Get to the cause. There is some myocarditis happened for what she was ill for last 3 days, having fever, and we diagnosed this as a case of viral myocarditis somewhere down the line. And if you can see the reports, the SGOT and SGPT, these are all the effects of shock liver, which has gone up to 5,000, 3,000, is getting settling slowly over a period of time for 3 to 5 days. And creatinine also coming down. And the X-ray after 3 to 5 days has improved. The pulmonary edema has gone. You are just supported on ECMO with that thing, and heart has started a bit improving. And then you decide the heart has improved, she's awake, she's responding, she's passing good urine, her shock liver has improved. Over a period of day 7, day 8, you start coming around on the ECMO flow. The initial ECMO flow was 2.37 liter, which is the initial cardiac output we are supplying. Then we are coming down slowly, 2.37 to 1.88 to 1.39 to 0.82. And then this is the thing when I am ready to decannulate the patient from ECMO as the saturation is 100, his pressures are good, his heart rate is fine, and she's doing fine. And with the lactate of 1.29. And we call the surgeon for the decannulation because at the hurried situation, I don't know how much high is the cannulation I did at that point of time. So it was a elective removal of the cannula we did. And this is the way we do. So this is what is if we face a similar kind of scenario, you need to see a team at your center, whether it's an ECMO center or not. And obviously, within a period of 30 to 60 minutes, if you can put the patient on ECMO, she can get the life. Now, what to expect? You will get the hypoperfusion, tissue injury, and lactate, which will gradually settle slowly, and the organ dysfunction. The problems, obviously, what he has asked is the cost. Who will bear the cost at that point in time, because no relatives will be around. Cause, you don't know the cause, what is a reversible cause. He had an earlier myocarditis or not, he has a cardiomyopathy which has got arrested, there is a chance of less coming out. Acute thing, poisoning, pulmonary embolism, they come out well. Cannulation, who will cannulate at that point of time, and to continue, how to continue. These are the feasibility issues nowadays. Now this is the lady who actually got arrested and just woken up after 10 days, and she went home after that. So this is the case scenario. What we are thinking, that a lot of younger people are getting arrested because of MI, or even in hospital, even on the out of hospital, a normal cost of 3 lakhs. Because these kind of circuits what we are using regularly in the operation theaters, we can make them survive for 6 to 8 hours initially. If they woke up, if the ECPR is successful, then you can change over to a long circuit after the relatives arrived. So we have done that also, that we have reduced the cost and we can run it. No, Ayushman Bharat doesn't cover it till now, but from ECMO Society of India and from ISCCM, we are writing to the government that it should include this kind of circuits for this thing, because a lot of postoperative cardiac patients they require, a lot of postoperative liver patients they require, so a lot of patients are requiring. Yeah, they should. This is nothing but an extension of your regularly using cardiopulmonary bypass for a longer time. You are doing nothing, you are just putting 2 pipes in the body, one in the artery and in the vein. It might look very costly, it might affair, but you are doing nothing, you are just putting 2 pipes.
The thing to convince the relatives, that is in short span of time, have a sudden cardiac arrest, we are doing the normal CPR, adding a cost of 50,000 or 1 lakhs with a minimum guarantee of returning to the normal. That is, I think, is the most difficult part. So, yeah.
Yes.
Additional cost with a poor outcome. That is the thing.
30 minutes of failed ROSC, then you consider, or you can consider it earlier?
So you cannot just pinpoint that 30 minutes sometimes, because what is happening is not coming out. And you have a third sense that he's not probably coming out of the recurrent arrest is happening, and a kind of younger guy. I'm just pressing on those situations, younger population, having an MI. Yeah, it's a kind of 30 minutes, 20 to 30 minutes. We consider if the good quality CPR is ongoing, patient is going to be awake, because whenever we are putting him or her on ECMO, we do reduce the temperature to 32 degrees. So some amount of brain protection we do on ECMO, because you can reduce the temperature on ECMO. So that is added advantage. So other cerebral protective measures you can do. Even with that, the good quality CPR has to be there. That's why he has asked the out of hospital cardiac arrest. The basic hindrance is we have not taught our people to do CPR. Yeah, people will do everything without CPR.
The society people should learn to the
You are the boss of ECMO now. All over India, you are very famous. But the thing is, how do you manage the party? I mean, the patient's relatives within a short span of time of so many lakhs of rupees involved, 25, 50 lakhs. How do you take the consent of the patient in such short period of time that I will initiate ECMO within 10 minutes? Very difficult.
Yeah. There are difficulties, but I am telling you the other way around. It is the sometimes the patient relative will ask you whether you can do something else? Be prepared to give that answer. Okay, I'm getting those questions now. You know, whether, yeah.
Is that whatever facility is available in your hospital, you have to offer that. It is in your
Has not become a standard of care. I'll just tell a story to you because the Qatar World Cup, last Qatar World Cup, the Qatar tried to put ECMO machines in the stadiums because you have seen probably a lot of footballers are having cardiac arrest during the play and all these things. So, but ultimately they could not because FIFA told that it's our responsibility, and if I start this kind of thing here, Qatar, if the next World Cup is in Brazil, if they can't provide, so that should not be a norm. But they have kept all the CPR arrangements at the in the stadiums. So it has happened. So this is coming in a different way. This is coming. Yeah. This is coming. Cut-off age, we have kept lesser than 60. Okay, it should be lesser than 60. More than 60, we are not considering for them to ECPR. But also, I am telling you, that varies. It's India, you know, we have to put sometimes the older patients also if they are otherwise fine and they are doing okay at that point of time. Our target is more than the myocardial infarction, young myocardial infarction, they should not die of immediate cardiac arrests. Thank you. Thank you, sir.
Very interesting.
Right, thank you, ma'am.
Well, I will be getting it.
Thank you.
poisoning cases, paraquat poisoning, but there is no use in paraquat.
We don't put. We put self first.